Hi, everybody. Thank you so much for joining us today. My name is Mericka Lehman, and I'm part of the sales team at Mindlift. And today we are going to be having a question and answer session to go over specific questions pertaining to neurofeedback. These questions are ones that you all have submitted, and we will definitely try to get to them, as many of them as possible. But do know that if we don't, we are going to follow up with you all via email. So anything that we weren't able to review today, hopefully we can get all of that answered. We are really happy to have you all here and appreciate you taking the time to sit down with us. Our guest today is Dr. Nathan Brown. You may remember him if you attended our last webinar using neurofeedback to achieve better patient outcomes. And if you weren't able to attend, you can find that on our YouTube channel, and we will be sharing that link for you in the chat. Dr. Brown was our gracious guest for that webinar, and he will be our guest today as well. So the way that this is going to work after I introduce Dr. Brown is I will go over a very short demo just to show you how the Mindlift platform works, especially if you're not familiar with this system. And do note that if after the short demo you do want to learn more about this system, feel free, let us know. We'll reach out to you and set up a time to set up a full demo for you. Anyway, Dr. Brown, he has over 35 years of experience in the clinical, organizational, and community mental health fields. He's received specialized training in psychotherapy and assessment, health psychology, and prevention-oriented community psychology. He maintains a full range private practice while he works primarily with adults and older adolescents, coping with depression, anxiety, cognitive and attention issues, and the effects of major life stress, trauma, and change. In addition to clinical work, he has held academic posts at Fuller Graduate School of Psychology and at Seattle Pacific University as Dean and Associate Professor in the School of Psychology, Family, and Community. Dr. Nathan Brown is also a member of our clinician network at Mindlift, and he will be our speaker for today. We're thrilled to have you back today, and we're looking forward to this Q&A session. Before I begin, I am going to go ahead and pull up my screen. Let me make sure this is working. Here at Mindlift, we are a platform that enables you to offer neurofeedback both remotely and in clinic to your patients. We have made it really as user-friendly as possible, not just for you, but for your clinicians, for your clients as well. The way that the system works is that you, as a clinician, run everything off a clinical dashboard. It doesn't require any fancy computers or any fancy software. Anywhere that you have a Wi-Fi connection, you will have access to your dashboard. And then your client runs everything off their app, which is super simple. They don't need any fancy computers as well either. So they download everything off their mobile device. They're able to access their app, and then you run everything off your clinical dashboard. The way the hardware works is we run off a Muse headband, which I'm putting on right now, with one added electrode so that you can move that electrode around and train any of the 1020 locations. The great thing with Mindlift is that in addition to the neurofeedback, which is the heart of what we do, you will also have access to different assessments and digital tools as well. You will be able to do symptom tracking using standardized questionnaires that are built into the system. There's 40 of those to choose from. If there's anything that you want to add in that's not available, you can absolutely do custom questionnaires. We also have a continuous performance task that you can use. This is just a test to help measure someone's sustained focus and attention over time. And then, of course, the EEG sensing so that you can do brain mapping using our hardware now, which we're super excited about, as well as gather other EEG metrics. Different tools that your clients will have the ability to access include journaling, meditation, breathing exercises, and there is a capability to communicate remotely with your clients via the system as well, if you find that applicable. In terms of the remote neurofeedback space, we really have started to become leaders in the space. We have over 400,000 neurotherapy sessions logged on the system. We have over 18,000 clients and over 9 million minutes have been trained. We recently published a study showing the efficacy of our remote system on different mental healthcare issues, with seeing massive improvement in over 61% of the participants. And that was following 560 different people, with the biggest improvements in scores in the ADHD and anxiety scores. In terms of being able to offer neurofeedback for your clients, we have developed an applied learning program. So if you're not trained in neurofeedback, or if you need extra training in neurofeedback, we now offer a mentorship program where you would get matched with a neurofeedback expert. This expert basically is there to hold your hand for around 12 weeks and guide you throughout the neurofeedback protocols, setups, and working with your clients and teaching you how to implement that into your practice. I am going to go ahead and pull up a video to show you how the platform works so that you can get a visual of how your dashboard would look, how the client's app would look, and also some of the really cool data that you can pull from. So the way that you add clients in is really simple. You will get a unique clinic code that you can share with your clients. Once your client downloads the app, they enter in that code, then they get linked to you and only you. This is how it looks when they're logging into their app. And of course, what they see in the app and what you see on the dashboard are completely different things. When you're ready to go in and add a client, super simple. You just go in, you have the capability to give your clients different tags. These tags just tell the system what your client is dealing with. And from that tag, it would auto-populate suggested questionnaires. Of course, if you like that feature, you're able to continue to use that. And if you don't, you could potentially just say everyone is healthy, and then you would pick which questionnaires you want your client to do. All of these things can be made to be recurring, including the different assessments. So from this screen, it's super easy to toggle on and off anything it is that you want to track over time. So maybe there's some clients that you really want to do the questionnaires with and the EEG sensing, but for whatever reason, you don't want them to do the continuous performance task. No big deal. You would just toggle that off. We try to make this system really fluid and really customizable. So anything that you want to personalize for that specific person is easy to do. This is just showing you how easy it is to make it recurring. Maybe you'd like them to do an assessment every 6 weeks, and then you would just put that into the system, and you would not have to remember to remind your client that it's time for their assessment. The app does it for them. In terms of setting a neurofeedback program, I won't get too much into this, but I do want to mention that everything can be customized. There are preset protocols that are already built into the platform. This is all based off the literature and on neurofeedback experts' input on what they're actually using in the field. But that being said, if you wanted to create a custom protocol for every single client you're seeing, you do have that capability. You also have the capability to give your clients multiple programs, and you can set this up in a few different ways. User choice, meaning that the user chooses, of course. You could do alternating, meaning maybe they do program A followed by program B, or sequential, where you would do maybe 5 sessions of program A followed by 5 sessions of program B. So like I said, everything can be customized as you see fit. I'm going to fast forward just a bit so that you can see what it looks like in the app. So when your client is ready to train, what's really nice is the software will remind them, this is where you're placing your electrode. This is the program that you've chosen to do. And also, are you doing eyes open, eyes closed, etc. It will go through an entire signal quality check to ensure that the signal is good before they train, and then it will do an entire calibration based on what's happening in their brain at that time. Then when they're ready to train, what's nice is they have different games they can choose from. Sorry about that. These games all have different feedback mechanisms. In the specific game showed in this video, it's the runner game. The feedback here is that when they are in the zone, when they'll be running nice and fast, and as they fall out of that zone, they'll start to lose their race. If they get sick of the games, it's not a big deal. We have YouTube built into the app, so they have the capability to go in, search a video, any video that they want, and then be able to do training based on the YouTube video. I'm going to fast forward just a little bit. We do also try to make it very interactive in between training sessions in the app. So in between meeting with you, meeting with their provider, they'll get feedback. They'll get things like, it looks like you've trained 20% more this week than you did last week. They will even be able to take an entire educational journey, learning about neurofeedback, learning about what a brainwave is and why it would be important to them. There's a ton of data that you can pull. I won't go too much into it, but do note that anything that you want to keep track of over time can be put into a visual. Sorry, I don't know. This video is playing so strange on this on here, so apologies for this. I'm going to actually unshare it because it's just being really weird, but I'll talk you through it. You can pull, all of their EEG metrics. You can gather all of their symptom questionnaires, all of the assessments. All of that can be put into a nice visual chart or graph, depending on what it is that you want to see. You can create beautiful progress reports for your clients that you can share with them. And so they can actually get something visual and take something that's super abstract, like neurofeedback training, and make it tangible for them to understand. So if you want to hear more about this and I can show you how it works, please feel free to reach out. And then we'll reach out to you and set up a demo. But now we'll get into the heart of the webinar. So nice to see you, Dr. Brown. Well, I'm going to start off with some questions that we actually have chosen, actually really you have chosen to lead us off. And so first and foremost, how do you determine if your practice requires adding neurofeedback as an additional service to offer your clients?
Okay, well, I feel like this is a great question to kind of kick off the conversation with, because it kind of centers, to me, that question centers around your practice. In my experience, I've seen people from many different professions that have been drawn to neurofeedback. I work with and I'm aware of folks using neurofeedback that are in any of the mental health specialties, but also naturopaths, chiropractors, medical specialties, and also coaches, people who perhaps have come more out of a business or organizational background, and they're trying to work more on performance enhancement. So I think the first way of getting at that question is to ask, what's the essence of your practice, both in general in terms of your discipline, but also in particular, what your particular interests are. I happen to have wide-ranging interests, so I use neurofeedback in working with folks with clinical diagnoses. I do a lot of work with attention deficit, for instance, and depression and anxiety. But I also work with a lot of people who've come out of the sports world or the business world, and they are simply trying to raise their game. They don't have a DSM diagnosis or even a medical diagnosis, but they're wanting to improve their capacity for decision-making and the like. So I think you've really got to start by asking yourself, what is it I'm particularly interested in offering? And then the second part of answering that question would be, is there a biological component? If you think of the biopsychosocial aspect of most issues, that people deal with in their life, is there a biological underpinning to that perhaps we could get at through neurofeedback? The relationship between the brain and the mind is complex. We're kind of cracking the window open a little bit, have been in cognitive neuroscience for quite a while, and the neurofeedback work in particular. We know some things about what brain function may underlie certain mental states and also physiological states that people are experiencing. And so if you find that you're dealing with clients who have issues that maybe have a strong, let's say, psychological component or a strong physical component. I work with chronic pain. I work with physicians who are working with folks with chronic pain for which neurofeedback can be helpful.
Super interesting. That question alone could lead us down a rabbit hole, but I will stay on track. How to ensure that my patients have successful / positive neurofeedback training results?
That's a really good question, and it kind of implicit in the question is an understanding of something I want to kind of really emphasize here, which is neurofeedback is first and foremost, the practice of neurofeedback first and foremost is a therapeutic relationship. It is as much a therapeutic relationship as psychotherapy or medical practice, any other of your, more day-to-day practice. All the therapeutic kind of rules or principles in terms of how you develop a productive relationship apply. I tend to think of this as kind of falling into two categories in terms of making sure patients have a successful experience. One is readiness. And what I mean by that is, are they in a condition, in a place in their life where they're going to be able to devote the bandwidth that it's going to take to do training? This is not a casual, sort of spend 2 minutes a day on it. This is something that it's like going to the gym in some respects. It's something where it works when you show up and you do the training. So first and foremost, you want to make sure that folks understand that, that this is training that the payoff potentially is permanent change in the brain, resetting the brain, you might say, to factory conditions. But to get there requires engagement. And so you want to make sure folks are ready for that they understand sort of what that's about. Secondly, in addition to readiness, I just gave one example around readiness. We can talk more about that if you want. But the second part of it in my mind has to do with setting appropriate therapeutic expectancies. And I'll give you just an example of that. People come into any kind of healing relationship quite often with misconceptions about the nature of healing. I have patients who have come into my office for psychotherapy, and they've been to 20 different therapists in the past, and they sort of have this model of healing that says, I'm just looking for the magic pill. I'm doing poorly. If I find the magic pill, I'm going to do great. If I were to chart it, all of a sudden I'm doing great and everything's perfect from then. Well, most people understand that's kind of a myth. That's really not accurate. But there's a second myth that people have that's more subtle, and it's the myth that every day in every way, I'm going to get better and better. So I better be doing better today than last week, or something's terribly wrong. Now, the fact of the matter is, any form of healing, and by the way, Mericka, you're going to have your hands full keeping us on track, because I have a tendency to kind of want to go down some of these rabbit holes. Any form of healing, all the way from broken bones and how they heal, all the way up through healing from something like anxiety or depression, follows a trend that is much more like this. We have progress and we have regress, and progress and regress. When bones break, they knit together and then they unknit, and then they knit stronger and they unknit. And so even at that physiological level, you get this kind of recursive process to healing. If your patient doesn't understand that in psychotherapy, it may not be as big an issue in neurofeedback, because you don't have all that outcome data, right? With neurofeedback, we have a wealth of data. And so if patients or clients don't really understand there are going to be some ups and downs here, your brain actually needs a poor session to learn what not to do, as much as it needs to learn what to do. Patients have to go in with the proper kind of expectancies around that. And if you set that up properly, and by the way, I would say this simply draws on what many of you as clinicians already know. A lot of what I want to communicate today is, if you are in a health care profession, whether you know it or not, you already know probably 30 or 40% of what you need to succeed in neurofeedback. And this is a real key one, is how to manage the therapeutic relationship. Okay.
I love that. And yes, it's making me want to go down more rabbit holes. But I do love the brain has to learn what not to do. It's like you can tell somebody that the stove is hot, but until they put their hand on the stove, they don't maybe not believe you. So I love that. Okay, and I will stay on track. This is actually a question from a clinician. So this is Andre out of New Westminster. Thank you for this question. How can a counselor reliably match symptoms or diagnoses with treatment protocols?
Oh, Andre, you're my plant in the audience. That's a fantastic question. The answer to that, first and foremost, is a proper assessment. When we do a neurofunctional assessment, which the Mindlift system provides, there are other ways of getting those assessments, but it's built into Mindlift. What we're getting is what we call latent traits. Those are traits that exist at the brain level, and those traits may or may not be expressing. They may or may not be showing up in terms of the person's actual experience. I will work with people, for instance, who have certain latent traits that suggest a propensity towards depression. They may not be experiencing depression at that moment because so there's sort of a mismatch, if you will, between latent and expressed, simply because the conditions aren't there yet. Given enough stress, given enough, maybe poor self-care or whatever, they are going to, this is likely the way they will tend to move into dysregulation. So having a proper assessment gives us an idea of those latent traits. If we've done a good job with the identifying the expressed traits, and we can do that through clinical interview, we do that through assessment. Mindlift provides good basic assessment in this regard, and clinical observation, what you're seeing when you're meeting with the individual. Then we have an idea of where those latent traits and expressed traits overlap. I'm trying to do a Venn diagram here, where those overlap. And it's that sweet spot in between where the overlap is of latent and expressed traits. That sweet spot is where we derive protocols. And the protocols that we derived are evidence-based. When you look at the neurofunctional assessment, which is maybe a webinar we could do at some point, what you're going to see are empirically based data, empirically based statistics and ratios that tell us here's a specific latent trait that is associated with variables, outcome variables of interest. They're associated with depression or anxiety or tension. Okay, so assessment is the short answer to that question.
I'm going to jump back to a different recommended question from us. And that is, can I offer other forms of therapy while providing neurofeedback? If so, what's the best recommended method to do so?
Boy, that's a great question. I would say, personally, most of the work that I do is a combination of psychotherapy and neurofeedback. When I'm doing, I'm quite frequently doing them together. I would say, in terms of best recommended method, I would take a step back from that question and come at it a different way. I would say what you want is to look for conceptual links between what we understand in terms of neuroanatomy and neurofunctionality and your particular therapeutic orientation. For instance, cognitive behavioral therapy, interpersonal therapy, many of the trauma-oriented psychotherapies, there's some pretty straightforward evidence-based links between what we know is happening at the brain level with what we see at the psychological level. So I find that piece is pretty important. I'm hopeful that in these webinars we're gonna get to speak specifically to some examples about that. Depression, we were mentioning a moment ago. So very, very direct correlation, I believe, between what you see most commonly in the brain with someone who's depressed and what they're and how a cognitive behavioral theorist would look at what's happening. Okay.
There was one that caught my eye.
Yep.
And I really like to hear your feedback on this because you've been doing neurofeedback for so long. How do you get started after choosing to add neurofeedback to your practice? And even how do you go about choosing that equipment, service, integration, etc.?
That's a good question. Mericka is referencing, I usually say that I've been doing neurofeedback since dinosaurs ruled the earth, which raises an image of a T-Rex with a headset on, I guess. This is a really good question because the field has been so scattered. Every system is different. It's a little bit like the Tower of Babel, trying to understand what the linkages are between them. I would have to say the number one thing to do is find a mentor, find someone who's kind of been there, ideally someone who at least understands your profession as well as understanding neurofeedback. Try not to think of neurofeedback as this thing over here that is maybe helpful to patients, but it doesn't have a connection to what I'm doing. Trust me, virtually all of the disciplines I've worked with, there are conceptual links that you'll find very helpful. And if you can find that mentor, one of the kind of trick questions to ask them is to ask a question like, what's the best system out there? That's a trick question. It would be like asking a carpenter, tell me what's your best hammer? Well, the fact of the matter is you have different tools for different purposes. I use biofeedback equipment. I use neurofeedback equipment. I use all kinds of what nowadays we call electroceuticals in addition to neurofeedback. Inside of neurofeedback, I use different systems for different purposes. Mindlift tends to be the one I go to very, very often, primarily for reasons of the portability, the remote capacity, and a couple of other things that maybe we'll talk about. But you want to find a mentor who kind of has that approach to things, where they're able to say, we really need to ask for what purpose. Once you find somebody along those lines, then I think what you want to kind of what you want to look at is how feasible are these different systems for me to implement. There are wonderful systems out there that are 19 channel systems, and they cost $1,000 per channel. That's a lot of money. Kind of rules out a lot of clinicians. There are 2-channel and 1 single channel systems that can be remarkably effective, can either be used in combination with or solo. There's a lot of ways you can use a single channel system such as the Mindlift system to get at what you would be getting with those fancier pieces of equipment. And frankly, you're not going to be lending that 19 channel unit out to people to do remotely. So the Mindlift system allows you to then give them access in a different way. So you want to think about feasibility. Part of that would be affordability that you would want to consider. Another piece you'd want to think about is there an assessment capacity in this system? I believe that really separates the sheep from the goats, is whether you have a system that actually allows for an empirically based assessment. Mm-hmm. There are systems out there that are not necessarily bad systems. You can do training with some of these systems, but without assessment, you're kind of going blind. And it kind of puts you in a position of not having a basis to measure progress. We need a theory to have an idea of what success looks like. And in order to figure that out, we need a theory that has an assessment attached to it. So you want to make sure that there's a good, robust assessment attached to any system. Finally, I would suggest you want something that offers the most breadth and flexibility relative to the cost and the other feasibility issues that you can look at. You want to have a system that will allow you to train potentially anywhere in the brain. If you have a system, and there are some out there, that simply train, for instance, they're doing SMR training at the top of the head. That's a very, very common protocol, and it can be very helpful in lots and lots of cases. But as soon as you go off that target, you aren't able to do anything with that particular piece of equipment. So again, hammer, it's a form of hammer that would be really useful for that kind of training, but I'm not sure you'd want to limit yourself to that.
Thank you. Very informative. And I'm going to jump to this question because I think it goes back a little bit to the answer where growth isn't linear, right? Like you're expecting this. And so this is from Celine. Hi, Celine, out of Calabasas. And
hi, Celine. I think I know you.
How often would you suggest changing the client's program?
Oh boy, Celine, you're my plant, another plant in the audience. This is a great question. Let me start by saying, let's think about the two extremes. One would be you have a clinician who says, I'm going to develop a protocol. Maybe it's based on an assessment, and I'm going to have them do that training the entire, let's say 3 months, 4 months, whatever the period of training is. I think of that as fire and forget, like the military think about missiles. You push the button and then you quit thinking about it because it's going to just do its own thing. I'm here to tell you that will not work, or it will work in a very limited way. Why is that? Because neurofeedback at its heart is operant conditioning for the brain. There's some very simple rules around operant conditioning, one of which is as you start training, you change the organism. Okay, as you start teaching anything from a rat all the way up to a person, the rules the dynamics are going to change, and so you have to modify. So that's one extreme, fire and forget. The other extreme would be patient comes in, you ask them how they feel, they say that, well, I'm anxious today. So you give them an anxiety protocol. Next week they say they're depressed. You give them a depression protocol. Next week they say they're having trouble concentrating. You're not going to get anywhere with that. Same reason is operant conditioning. If you had, I'm sure most people in the audience are familiar with B.F. Skinner and the rat pressing the lever to get a piece of cheese, right? In principle, that's sort of what we're teaching. Mericka, remind me to say what the cheese is in the case of neurofeedback, because that's a rabbit trail worth going down. If you teach the rat once to press the lever and he gets the cheese, but the next time he has to press a button on the wall, and the time after he has to spin around, is there going to be any learning taking place? No. So you have to have something in between these two extremes. And there's a training sequence that I recommend, that I teach in our Mindlift roadmap, that basically is getting at how do you balance between that adjustment versus, making adjustment versus allowing the training effect to take place. And in a nutshell, I could go down a deeper rabbit hole. I'll just say this much. There are two phases in neurofeedback, and this comes straight out of operant conditioning. There is the acquisition phase, and that's the phase where the brain has to learn what we're asking it to do. In that phase, you generally do not want to tinker very much with the protocol, because you want the brain to understand, so to speak, to learn in operant terms what we're asking it to do. Phase 2 is generalization. We generally want to teach the brain to sustain that pattern longer, because that's what allows a more adaptive form of functioning to occur in the brain. And you want it to generalize outside of training. Otherwise, what's the point? If they only learn to have better attention during the training and not out in the world, it wouldn't be very useful. So we want that. So in phase 1, we tend to make adjustments to the reinforcement schedule, the rate of reinforcement for each of the frequencies we're training. In phase 2, we're doing some things to encourage the brain to move longer. Okay.
Great. Awesome. I am going to ask this question from Aubrey. She's in Charlotte, because it does, I think, kind of cover some other questions that we've received from clinicians. Catherine, I see you. Hi. I hope this answers your question. What are the best applications for Mindlift amplitude training?
That's a really good question. I think the best way to answer this would be empirically. Amplitude training and neurofeedback training more broadly We have evidence that that certain forms of neurofeedback training are quite valuable for attention and concentration. Let's put that one on the table. Anxiety would be a second one, for which there is the strongest evidence of a consistent response. Secondarily, there is quite a bit of evidence around depression, around people with TBIs or seizure disorders. There's a good bit of empirical evidence. If you want to know the specific answer to the question that you posed, Aubrey, I would suggest finding this book. I hope that's not backwards to people looking at it. This is put out. This is put out by the AAPB. It's by Tan et al. This book is Evidence-Based Practice in Biofeedback and Neurofeedback, 3rd edition. Perhaps we can put this in something in afternotes for the webinar so you all have access to it. If you go into this, there are 44 chapters of different conditions and the state of the neurofeedback research in terms of efficacy. So really specifically, Aubrey, that would be the place I would go to look for this in terms of this. I would just add one last thing is attention and concentration. You know, we tend to think about that simply in cognitive terms, you know, how well somebody's, let's say, doing schoolwork or something like that. But attention and concentration is also the foundation of emotional regulation. If you're having difficulty with attention and concentration, that means you're having difficulty even recognizing you're having an emotion, right? And let alone being able to process it. So this is where we see benefit in some of the other psychological disorders is when we see the kind of foundation is really rooted in emotional regulation.
Okay, let's see. There was one that caught my eye. Oh, I like this. Okay. This is from Denise out of Big Sky. Do you prefer dynamical over linear neurofeedback? Why or why not?
So dynamical, we could go down a rabbit trail with this. I'll just say a couple of things. Dynamical neurofeedback is probably referencing the neurooptimal system. There's some other systems kind of like that. And it's essentially non-hypothesis, non-assessment driven approach to training. It does have research around it that suggests that it can be helpful. I tend to think of that training because it's non-specific. It's sort of training the entire brain's response. It's sort of trying to down-regulate or at least appropriately regulate the brain overall. So you might think of it as having this kind of general, I'm going to say non-specific. I don't necessarily mean that's not powerful. I just mean by definition, it's non-specific. It's kind of targeting the entire brain. I find that can be helpful in some circumstances. Again, is it a hammer? What kind of hammer are we talking about? There are other times when I might want to use that perhaps in combination with linear feedback, linear neurofeedback. Linear neurofeedback would be more the system that Mindlift and thought technology and some of those other systems will use. I would say that from the standpoint of having a kind of a theoretical rigor to what you're doing and why you're doing it and being able to test outcomes in these systems, it's easier to do in general with the linear systems.
And I'm going to transition that into another question. This is from Hadassah out of San Diego. Discuss transition from othmer method infralow frequency to the Mindlift home device.
Boy, also a really good question. We could have a conversation about the othmers. I think that's really interesting. So some of you all may not be familiar with this. This is infralow training, which is sort of operating on an entirely different spectrum. The theory kind of underlying is different. I'll just speak to the transition part. And what I would say is, in terms of what would be helpful in the transition, is going to be that assessment. If you are a receiving neurotherapist and they're coming from othmer, It would be helpful to get whatever notes or other information records, assessments that they may have generated through that. Not actually essential to be able to look at what's happening in the Mindlift system. We would then just want to do an assessment to kind of take care of that. You're going to find that there is more of a connection between the slow wave activity that we're getting with Mindlift and the infralow work, because it's kind of on that end of the spectrum.
Very interesting. Okay, let's see. Oh, I love this question. And this is from Steven out of Rockledge. It's what contributes to compliance regarding home practice?
Also a good question. I have to say, let me just say, first of all, many of us have entered the wonderful world of Zoom during the time of the pandemic. And if you're a therapist like me or someone in another discipline who's been doing Zoom work and having to do this remotely, I don't know if you've had the experience I have had. I have felt a loss of not having people in person. There's something you lose, but there's also something you gain by being able to be invited into their home. And so the way I tend to do the Mindlift system, and I'm doing this with folks literally around the world, I set them up with a training, and then we meet on a periodic basis, and I have an opportunity then to literally be invited into their home. And sometimes you get some clues about what might be happening that might inhibit compliance. I'll just give one example. A person I was meeting with, I don't even think I'll say the country. I'll keep this confidential. But she was coming for attention training. She was having trouble with attention. And there is a brainwave that several locations, but at the center of the brain where we were doing the training, there's a brainwave called high beta that has to do with distractibility. And her high beta was off the chart. I've never seen such a high level of high beta. And so after a little while working with her, it just was not coming down. There's some things that you can do with neurofeedback to kind of move it down. So we had a very careful conversation about what's happening during the training. Well, it turns out during the training, she was ironing. She also had 3 kids who were running around the room. And I had her do the neurofeedback in real time. That's how I found out. That's what's going on. So kind of a humorous example. I mean, the obvious thing there is, let's try and not do that. If you're working on attention, don't set yourself up like that. So, essentially compliance, I think a couple of things. One is you want to make sure they've got those expectancies well understood, that this is training, there will be ups and downs. Secondly, you want to make sure that there is a quiet environment, that they're not going to be interrupted. Thirdly, you want to make sure that they are not, this is pretty important, that they're not trying too hard. So here's a pretty key principle in neurofeedback. Actually, it's a principle in psychotherapy. The key to resiliency and being mentally strong in life is the ability to focus on what you can control and not on what you can't control. Well, guess what? You can't control your brain waves directly. If you try, you will fail, because what will happen is, let's say we're trying to train down anxiety. If you're watching that little runner, and how come he's slowing down? What you're doing is you're driving up high beta, which is distractibility. Okay. So that kind of attempting to control something you can't control actually is something you see very clearly in neurofeedback. And if you're thinking about your patients through this lens, you will see it very clearly in their lives as well. They're trying to focus on things in their lives that they can't control. So what can you control in neurofeedback? I would suggest there's 4 things you can control. Number 1, have an attitude of curiosity rather than control. Okay. Often, if I'm dealing with someone who is a very, kind of driving, high control, intensity kind of person, I will say to them, you've learned half of what's really important in succeeding in life. It's really important to have that kind of grit and kind of leaning into it and trying to bend things to your will, so to speak. But there's a good bit of life that does not work. right? If you apply that attitude to your spouse, for instance, trying to control them, not going to turn out well. Okay. So that attitude of control, this isn't just a neurofeedback thing. This is a miniature lesson in life. I think quite often, the more I do neurofeedback, it's like you have a little laboratory the size of your skull, and you get to learn how to let go of the things you can't control and focus on the things you can. So have an attitude of curiosity. What am I aware of that's happening in my brain, inside of me, that correlates with what I see on the screen? That's curiosity. You might think of it as mindfulness. Secondly, focus on your breathing. We're generally looking at down regulation, and breathing, particularly with a long exhalation, which triggers a vagal response that sends a message to down regulate, is quite helpful. Thirdly, find a point of focus. Find something to focus on rather than where that runner's arms are. Find something in the background to focus on. Let the signal come in kind of peripheral. Fourthly, don't worry too much about the numbers, because the numbers are going to go up and down, as we talked about. That's actually a sign we're doing it right, not a sign we're doing it wrong.
I really like your 4 points for my own sake.
To me, the most rewarding parts of neurofeedback are seeing how it just, at a brain level, it just underscores some of the truths we know at a psychological or physiological level.
Yeah. All right. This question I'm going to ask, and I do think that it probably will answer some other questions in the audience. Yeah. This is from Sharon out of Boca Raton. What is the general success rate for neurofeedback? And what types of things can you use it for? Although I think we already answered that. How soon can you expect results?
Also good questions. You know, I'm kind of an empiricist, so I think the first thing I would want to say, again, a short answer to the question would be use as one example. There's certainly others in the literature, but use as one example the Mindlift report that Mericka, you just referred to. I think it's looking at a 60% rate. You always want to kind of keep in mind that, you know, that's research, and applied situations can be a little different. That patient element, you know, the therapeutic relationship element carries a lot of weight in terms of the success of neurofeedback. I would estimate in general, so you have to make a lot of generalizations to answer this, but in an uncomplicated case, where I'm going to be even more specific, an uncomplicated case where what we're dealing with is attention or concentration, we're generally looking at about a 2 to 3 month period of training. Okay. If it's, this varies depending on circumstance. If it's a sleep issue, it might be less than a month. You do some particular training for sleeping. If it's complex trauma, you know, it may be quite a bit longer than that. But let's stick to the 3 month kind of period. That's kind of a general time frame for success. What I mean by success, we have to think about this. One level of success is, are the numbers moving in the way that we would want, right? The system generates some good tracking numbers. The second is you want some idea of what the actual improvement is out in the wild, outside of the training. You know, are they actually succeeding? The question as to how soon you can expect results goes back to the phase 1, phase 2 question I was talking about. So if you think about it, phase 1 is acquisition. It's getting the brain to understand. I'm kind of personifying a little bit the brain, but you're trying to get the brain to learn to respond to reward, to move these brain waves into a particular pattern. Again, depending on protocol, that might take, let's say that's simple, 2 to 3 months. That might take 3 or 4 weeks to get there. I do not expect much of a change in people's experience inside of that phase. They almost certainly will feel more relaxed. Most people in general will feel more relaxed, and maybe some general, you know, well-being and that sort of thing. But in terms of the target, like the focus on attention, we tend to see that more by definition in the generalization phase, because the generalization phase is the phase in which we're teaching the brain to hold that pattern longer You might think of it as we're soldering down the loose wire so the rest of the brain can take advantage of that increased capacity. And we're teaching the brain to generalize. This generalization phase is the phase in which neuroplasticity tends to take effect. What I mean by that is when you do this training long enough, you literally are changing the structure of the brain. We're increasing dendritic connections and sort of resetting the brain in a sense to function more adaptively. So it's really during that phase 2 period that I would expect to begin to see change. And in my experience, it's sort of a hockey stick graph in terms of improvement. Phase 1, you see a little bit, not much. Phase 2, because that's when we would expect to see the change, it tends to increase.
Awesome. And it's 69% improvement from that study.
There we go. I was rounding down.
And we'll send a link to the study in the chat as well. So.
I didn't answer that part. In terms of my general experience with my work and with folks that I'm supervising, I would generally say we're getting moderate success rates at least in about 75 to 80% of the cases that we work with.
And that actually flows right into the next question. This one's more specific, but I think we could make it general as well. This is Benjamin from Holly Springs. Mm-hmm. After 3 months of daily neurofeedback for clients with ADHD, how long do the effects last?
Oh, great question. So it was sort of implicit in what I was saying a moment ago. If you take that 3 months of training, and I love that you said daily, by the way, because this is cumulative. There's a whole conversation we could have about the dosage effect with neurofeedback. 3 months is kind of a standard length of time. Those effects in general tend to persist after that. You tend to get relatively permanent change. Now, does that mean that they may never need neurofeedback again? Well, I've had someone that I work with who was in high school and early college and was having difficulty with attention. We were able to get them off of stimulant medication. And so they functioned, they went through college and did well enough. They went into grad school. They got to their orals and they needed a little bit of a boost because they were now needing to expand capacity, if you will. Mm-hmm. Okay.
Awesome. This is Tekka. Oh, hi, Tekka. This is how to market Mindlift treatment to yoga sound healing students and other clients.
Boy, these are such good questions. Yeah, I've consulted with some yoga practitioners, and I think one of the things you can do, this sort of moves us more into potentially meditative states. I think I'd want to ask sort of what kind of yoga are you doing? Because sometimes mm-hmm. folks will do yoga for for being more flexible, or they're using it for pain or something like that. But if we're using it, almost more for getting that kind of meditative calm, there's some very natural connections between neurofeedback and yoga in terms of they're both basically different pathways to the same state. They're both different pathways to what we would tend to call an SMR dominant state in the midbrain, where you've got this kind of, I would refer to it as cognitive poise, kind of a relaxed concentration. I have to say that biofeedback, which is kind of the larger field, neurofeedback's a sub part of it, got its start when a group of psychologists and others went to India to study yogis who were practicing because they had heard that they were able to lower their heart rate down to 30 beats a minute, which is sort of coma territory, if it happened to one of us. And it turned out that they were able to do that simply because they'd done enough yoga practice and enough calming that they were able to hear their pulse in their ear. And by having that, that's a feedback loop. They could then have control over their heart rate. Whereas you and I we could use a stethoscope and get to the same kind of effect. So at any rate, yoga actually is sort of in the DNA of biofeedback and neurofeedback. because that idea of the principle of feedback really originated by that observation.
That's fascinating. And I'm actually going to ask another question. This is one from us. You kind of mentioned it, but maybe we could dive deeper. Is it ever advisable to use neurofeedback in combination with other monitoring training devices, heart rate variability, etc.?
Please do. Yes, yes. I would describe it this way. We are talking about, the broader term here is self-regulation, right? We're trying to use these various devices to achieve a more self-regulated state. And neurofeedback, you might think of that as sort of top-down self-regulation, right? That's basically at the brain level, teaching the brain how to regulate itself. And in turn, that tends to send regulating messages down to the body through the limbic system. If you don't mind, I'm going to use my cheap model of a brain. I don't have my regular model. Here it is. Here's your brain. Inside, you have the limbic system. My thumbnail is the somatosensory cortex. This is the part of the brain that talks to the body, and the body talks to it. Okay. So when we're doing training, particularly looking down at the limbic system, we are picking up the somatosensory cortex. And if there's dysregulation in the body, this is kind of the channel through which it happens. So at any rate, that's top down. Bottom up would be various biofeedback modalities, heart rate variability. The interesting thing is, even that idea of top down, bottom up sounds like the brain is on top, but the fact of the matter is it's a two-way conversation between the brain and the body. The vagus nerve, we know, is actually sending about 60 to 70% more messaging up than is going down. But when you use tools that are designed to get at the body, what you're doing is simply getting at the regulation we're aiming for from both directions. So I very frequently, for instance, will do certain forms of neurofeedback along with heart rate variability, just to pick one.
Yeah. And I'm super into that. We've had our conversation about it. There was one, here it is. This is Amber out of Chester. Is training theta for meditation and SMR/ADHD together bad for clients?
That's a really good question. Let me just speak to what's probably underneath that. Training for meditation, of course, we're talking about a slow wave. And you could be training in general around the brain. There are different locations you might want to upregulate theta for meditation. Very frequently, it's the front right that you're aiming for to get to a deeper meditative state. So Amber, I think the question underneath that is, can you do that, which is basically increasing a slow wave? At the same time, you're trying to do SMR training at the midbrain. What you're doing with SMR training is you're upregulating, you're enhancing a faster brainwave called low beta, classically is what you'd be doing, and you're downregulating theta. So if I come right to the heart of it, I think you're asking, is it okay to be trying to drive theta up here and down here, right, at the same time? So the response to that is the brain can walk and chew gum at the same time. The brain has to, over the course of the day, of a day, the brain has to be in all different kinds of states in order to function. So as long as you're not doing them simultaneously, that would be a little challenging. You're going to be fine with that. What I do with folks, if their schedules allow for this, is to do the more beta spectrum training, the training that's emphasizing faster waves earlier in the day, and then slower wave training later in the day, because for one thing, the brain is naturally starting to drive up slow waves as you move further into the day. So we kind of ride that wave and do that training in the evening. Okay. It sounds like that's for specific situations. I hope that's helpful.
Okay, this one's from Matt in Irvine. Can neurofeedback be used to rehabilitate from stroke?
Really good question. So stroke, there's a good bit of evidence around, not around, we're not going to heal necrotic tissue. If we've had a stroke and there's been damage to the brain, we're not going to heal that particular tissue. However, depending on the location and the severity of the stroke, with that whole notion of neuroplasticity, there is some evidence that we can build compensatory circuits in the brain that can offset some of that. Going farther probably is a more complex question. I'd need to know, kind of exactly what kind of stroke we're talking about. But in general, that can be quite helpful. It also depends on what you're actually trying to do, because I just spoke to the idea of sort of compensating for the actual stroke deficits. There are lots of other things that you'd be working with patients who are stroke victims around that may not be just that. They may be depressed, they may be anxious, they may have difficulty concentrating, and those could be helped.
Yeah. All right, another very specific. This is Chris. Hey, Chris, I think you're in Salt Lake. It just popped up on the questions. What is your experience and success in utilizing neurofeedback with autistic individuals?
Also, all of these are interesting questions. So autism is, as we all know, a very complex disorder. It's a disorder that there is some evidence growing around kind of the brain bases, neurofunctional patterns that are associated with autism. It's also something that, we're not talking about eliminating autism, but we would want to look at the particular, let's just put it this way, the diagnostic criteria for autism. For instance, if you're dealing with social difficulties, there are particular neurofeedback forms of training for that. I have to say they exist outside of the roadmap of the assessment that Mindlift has. This would be more training something called the anterior cingulate gyrus, which lives kind of behind the frontal lobes, and you would be doing something called gamma training. That would be one method that people have used. It's possible to do with Mindlift system. Another whole set of criteria around autism, of course, is going to be emotional regulation. And that is something that we have evidence can be helpful. Again, I would suggest you go to that the evidence-based book, and it'll give you a really good specific idea about that.
Yeah, thank you.
Yeah.
This one popped up in the chat as well, and this is Mary. Hey, Mary. I believe she's in Oklahoma. It says, how appropriate is the Mindlift system for working with clients who may have some seizure disorder going on, in addition to other clinical issues such as PTSD, chronic pain, etc.?
Okay, so seizures, neurofeedback really started around working with people with seizures. There's very strong evidence that it can be helpful around seizure conditions. I will say, if you're dealing with temporal lobe epilepsy, for instance, that's going to be something that occurs off the map of the basic Mindlift assessment. But it is possible to assess that. It's possible to figure that out and to do some training there or in other locations as needed.
Interesting. Okay.
Yeah.
And then and this is from Angie at Greeley. It's a two-part question. How to become a Mindlift coach, and how does Mindlift manage any negative side effects?
Okay, great. So by Mindlift coach, I'm going to assume that what Angie means is somebody who's not necessarily in a healthcare specialty, although you could be. I'm a clinical psychologist, and I do coaching, executive coaching. My basic, I'm going to focus on the Mindlift aspect of that and assume that you're already doing some form of executive coaching. The short answer to that would be you want to get trained in the basics of the Mindlift system and how to apply it. We have, I have to say, one of the most enjoyable things out of this year for me has been starting this Mindlift Go. It is a very it has a very applied focus. This is basically designed to get you up and running with the Mindlift system, give you the tools to get to basic competency with the Mindlift system. It's a training program that is open to, folks who are in coaching or folks who are in a healthcare specialty and want to kind of raise their game. So that would definitely be kind of the key thing, is you have to learn how to use it, right? I had a person I was consulting with them on how to get up and running on a different system, and she said, I bought this $20,000 system, and I feel like I was given the keys. It feels like I bought a rocket ship from Elon Musk, and now I don't know where to put the ignition key, right? You can have a little bit that feeling even with the Mindlift system. It's like, okay, now what do I do with it? And there is not nearly as steep as other systems, but there is a bit of a learning curve. And so again, you want to find that mentor and or find a system like the Mindlift Go system to do training. We also have peer-to-peer consultation if you prefer. Mindlift Go, we have one-on-one training, but you could also do that just individually with a trainer. How do you manage negative side effects? I would say comment number one to that, make sure you're well trained as a practitioner and you don't commit errors in the development of your protocol. You want to be really careful. One of the things I find is the most common underlying cause of error in this kind of training is that the practitioner doesn't have a regular routine system that they go through. So they kind of, there's just certain marks that you hit. If every time you're doing the training, it's like a brand new experience, you're going to make mistakes. And so you want to have a system that is kind of regular. Secondly, sometimes people do have some negative effects. The most common, and this is assuming we've got a proper protocol, the most common would be like headaches, or a sense of tension, kind of usually it's in their upper body. That is generally not a brain reaction per se. It's generally they're doing something different and they're concentrating and tensing their muscles enough that they're beginning to get some form of a diffuse tension headache. So if we get transient effects like that, first of all, I want them to tell me. I want the trainees to let me know if they're having any experience like that. Secondly, I'll work with them to just maybe slow down the pace at which they're doing this. This would generally be people who are doing it. I have folks sometimes who are trying to do protocols twice a day, which in general is not a problem. But it'll take a little while for, it's not so much their brain as their entire body to get used to this practice. Okay, so that's the most common thing I would see in terms of physical effects. There are other rarer instances where someone will have a strong reaction and it actually ties to maybe some trauma that they had in their life. I had way early in my practice, back in the 80s, I was actually doing biofeedback with a person. And, as part of that training, I asked her, just, sit back in your recliner, just relax. And all her numbers went up. Well, she had been raped 5 years before. And that was exactly what the rapist had said. So, those are the kind of things in a therapeutic relationship you really want to be aware of about what even this experience means. This is, by the way, one of the reasons why working with trauma from both a neurofeedback and a psychotherapeutic point of view is complex, is the whole experience of relaxation means letting down, letting go of your defenses. And there's a part of the brain right back here, the amygdala, that is sort of functioning as an alarm. And if there was trauma, this alarm is saying, stay tight, stay alert. So we have to be just cautious and thoughtful in terms of how we approach those kinds of moments, because you don't necessarily know how a patient, what those things that we say might mean to them.
Yeah. This is one recommended from us, and it's, how do you determine when to stop a client's neurofeedback program? If a client reaches target results, is it recommended to stop entirely or with less frequency to maintain their progress? Yeah.
I would look askance at any system that didn't have a well-defined stop point. That's kind of something to be skeptical about. I would say that there are I'm going to be really specific. In terms of the progress reports, there are 4 very specific criteria that I use to define success, by which I mean we have met the goals of the actual training itself. So that's one level of success. Now, hopefully, they've reached that level of success and they're experiencing success out in the wild, right? So I would be monitoring that and tracking that. You know what I mean by out in the wild, outside of the training. I'd be tracking that as well. So there are ways to define success. And honestly, if we're not getting there with neurofeedback, we may want to consider something else, or there may be a different protocol inside of neurofeedback. There's some protocols where we're sort of targeting one part of the brain, but it's like a game of chutes and ladders. It's also connected to another part of the brain. And so sometimes if we're resistant in one part, we can train through the back door, so to speak. We can train from another location. So the system I'm referring to with the criteria for success give you opportunities to ask those questions and to try alternatives. The second part of the question had to do with, kind of other, what I'm referring to as electroceuticals, monitoring devices and biofeedback devices that can be used. I very frequently recommend that. In fact, as they're in phase 2, the generalization phase, often, depending on what their presenting problem is, I'm looking for something that they can use that will be helping to consolidate the gains that they've had. Heart rate variability is a very common one, but there are others depending on what their presenting problem is. My goal is that by the end of the neurofeedback training, they have actually built, whether they thought about it this way or not, they have built a time in their schedule for a regular meditation practice. Okay, and that meditation can take many forms. Part of it can be neurofeedback, part of it can be yoga, part of it can be a mindfulness training, part of it can be HRV. I tend to think of that as a buffet, that they get to pick from day to day in terms of what it is that they might need. So that to me is one of my personal criteria for success, is hopefully we've helped them eliminate the symptoms, that they came in with, and we're giving them something preventive going forward.
Yeah. That's huge.
Yeah.
I love this question. This is also coming from us. What are some of the misconceptions you've received from patients in regard to neurofeedback? And what are some of the recommended resources we can share with clients to get them informed about it and its efficacy?
Okay, good question. So the number one, let's see, it was the question about misconceptions that they've got. The number one thing I think I hear from people, sometimes I don't hear it because I go out of my way to dispel it before they even say it, which is neurofeedback is not sending anything to you. It is not electroshock, right? It's not doing something to you. It's giving you an opportunity and your brain an opportunity to do something to yourself for yourself. Okay, it's a training thing. You'd be surprised how many people are nervous about this when we're doing something like neurofeedback, we're moving into territory that many psychotherapists don't cross into, which is we're doing things that affect their body. If you were if they were in office, you're literally putting an electrode on them, right? Even if you're doing it remotely, we're talking about things that you wouldn't ordinarily be talking about. So you want to kind of respect that. And one of the things that again kind of comes up is people feeling vulnerable with the idea it's going to do something to me. That's not what this is. The kind of related to that is a myth that it's not, okay, I don't believe that it's going to send electricity to me, but I do believe that if I just kind of sit back and iron, while I'm doing the neurofeedback, like I was saying before, it's just somehow going to work. Does not work that way. Neurofeedback requires this really interesting balance between engagement without trying too hard, without trying to control it. Okay. I actually first you'll find this concept in philosophy and in Buddhism, they call this nishkama karma, which is attachment to your action and letting go of the result. That's the middle space you want to actually be in neurofeedback. it's actually the middle space you want to be in your life, is focusing on the things you can control, letting go of the things that you can't. So that's a misconception that I'll see with people. Either the idea, it's just going to do it to me, so I don't have to kind of be engaged and have that attitude of curiosity, or they think that, on the one hand, it's going to kind of do it to me. On the other hand, it's something I have to try and control. Those are kind of maybe bookend things. What was the second part, Mericka?
Oh, and I just saw, is there any resources that you recommend sharing?
You bet. Great question. So I would, a couple of things. Probably the best single book I would recommend for end users, for clients, would be a book like A Symphony in the Brain. That's a really good introduction to neurofeedback. Related to that, if you have someone who's dealing with trauma, of course, The Body Keeps the Score is an amazing book, really helpful. There's a chapter in there dedicated to neurofeedback. The Mindlift website has got some really great information in it, and I'd absolutely recommend you go look at that. There are other sites like aboutneurofeedback.com is a site that's got some interesting information in terms of just general background.
Awesome. And I'm not just saying this because I work at Mindlift, but our website is a plethora of info. Our blog is amazing. So
yeah,
kudos to our marketing team on that.
Yeah.
Let's see. Oh, this one is great. This is out of Tomek, out of Vancouver. Is it ever recommended to redo the assessment if high levels of noise are picked up on the scan?
Yes. That's the whole answer. Yeah. We could talk further about what high levels are, and there are ways you can kind of work around moderate levels of noise, but absolutely, you would want to review that. Yeah. Otherwise, you're interpreting random data.
Right. And this is Marie out of Fortuna Foothills. What is important to consider when working with patients with TBI history?
That's really, really good. When you're dealing with TBI, one of the very, very important things is making sure you have a good history and a good diagnosis, right? Mm-hmm. So we have some pretty clear idea. If you've got TBI from a single incident versus multiple incidents, it makes a difference. And it makes a difference in terms of interpreting the assessment, which would be the second thing I'd recommend. You want a good, strong neurofunctional assessment, by which I'm referring to in the Mindlift case as the Mindlift assessment. Yeah.
Let's see. Okay, this is actually, let me pull up the question. And you kind of mentioned a little bit of this, but there's a few other questions on this sheet, and I think this will handle it. This is from Judy. Actually, I think I can share it up here. I'm an experienced feedback practitioner. I can't figure out how to make Mindlift work for me or my patients.
Okay. So I'm assuming, was this Judy?
Yeah, this is Judy.
Hi, Judy. if you're here live. I think I understand what you're saying. I'm assuming that you're used to a different system, and Mindlift has its own particular way of approaching things that are quite likely to be different from the systems that you've worked with. I've worked with a lot of people, including myself, who kind of ported from Thought Technology or Brainmaster or another one of the larger in-office systems to Mindlift. And it means a number of changes, right? You're moving possibly from a QEEG kind of system or a more complex multi-channel system to something that's single channel. And so there are technical things to kind of understand in terms of how those things differ. And there are also things in terms of the way you might convey these things, convey the results to the patient. This would be a really good example in my mind of where the Mindlift Go program, I do a lot of work with folks, just kind of helping them translate from one system to another. And I, there are folks that I work with in office with some of the larger systems, and then I'm sending them out to use the Mindlift system in a supplementary way, or I'm having them transition. And it can be done, but it's definitely something, they don't translate one-to-one. And you'd want to get with a mentor who can kind of help you understand those two.
Great, thank you. And this leads into another question, similar. How long does it take to be trained in neurotherapy?
So one answer would be forever, because none of us ever reach full competency. I still consult with peers and all of that. And I think ethically we are all bound to that, especially in something like neurofeedback, which is growing so quickly, and our knowledge base is growing so quickly. You don't want to be in a position where you think you can do this without any kind of outside help. You're going to want to have some folks that you have peer consultation with. And looking at different ways of providing that with Mindlift that I think I'm pretty excited about. But in terms of basic competence, that also has been pretty confusing. I'm a former professor, and so I kind of like to think about training and what does it take to get to basic competency. And when it comes to neurofeedback, it's hard to find the answer to that because every system's different, right? The certification, the BCIA certification, which I'm very much in support of, I think it's really great. But because every system's different, that training tends not to be quite as applied as often practitioners would want. It's got really valuable information in it, but they can't train to 20 different systems, right? So when I got involved with Mindlift, I got very interested in is this a system that is robust enough that you can train someone to basic competency in a limited amount of time? And so I think we've accomplished that with the Mindlift Go program. It's 10 weeks, 10 sessions. We will tend to speed the sessions up at the beginning and then slow them down at the end as you are just simply generating sessions, and we start to look at progress reports. But the intention of that program is to give you, here's our tagline, 738. 7 basic presenting problems, things like anxiety, depression, attention, that account for about 80% of what most clinicians will deal with. 7 presenting problems that center around 3 basic regions of the brain. We're not covering every area of the brain, but we're covering kind of the core. And inside of those 3 regions, there are 8 protocols. There's some variations, which would take us up to about 14 altogether. But those 8 protocols in and of themselves give you specific protocols to utilize when you're dealing with any of those 7 presenting problems. In my book, if we can offer a couple of tools that will help an individual who's facing one of those 7 core things that account for so much of what's in our clinical practice, I would call that basic competency. Particularly if you remember, as you go along beyond that, you want to have a cadre of peer folks to work with as you continue to grow and develop.
I just want someone put this in the chat. What was the philosophy word you mentioned?
The philosophy word.
I think it was the Buddhist.
Yeah, it's Hindu.
Hindu.
Nishkama karma. And basically the more modernized translation would be attachment to the action while letting go of the result. Okay.
Great.
Which I think shows up in pretty much any good psychology as well as any good philosophy or religion.
Yeah. We have 6 minutes left, and we have nearly gone through all of our questions. There was one that popped up. Brian Peters, I'll show that. Do insurers recognize and pay for a specific CPT code for neurofeedback, or should a doctor bill for a counseling visit or therapy visit?
Boy, it's a great question. Okay, I'm going to hedge a little bit, and then I'm going to give you some direct answers. The hedge is every state, every jurisdiction is going to have different principles. So you have to take what I'm going to say as kind of generally being the case, but there are always going to be exceptions. You asked about insurers specifically. There are insurers who will pay for neurofeedback, and they will pay for biofeedback. Aetna would be one of them. Aetna is a major provider, and they are an insurer, and they do tend to pay for neurofeedback and biofeedback. Primera, sometimes you have to fuss with them a little bit, but Primera, you can do a special case exemption, and you can get that covered. So there are some insurance companies that do it under the current system. However, Mericka, can I do a little teaser here? I haven't even talked with you about this.
Okay, please do.
So let's just keep this a secret between you and me and the 100 people who are here, okay? Nobody else say this. Don't pass this on. But I've been in touch with an attorney who specializes in these matters, and there are new CPT codes that have come out governing Medicare's payment for monitoring devices, in-home monitoring devices, and they will reimburse for that. Insurance companies, generally speaking, always follow Medicare's lead. So this is something that you can bet that this has kind of moved up my list of kind of got my attention. I would like to, Mericka, you'll have to let me, but I would like to do a webinar on this at some point and maybe have that attorney come in or someone come in and give some information about how that can be done. Personally, I am an out-of-network provider deliberately, and so the way we do it is the person pays us a time of service. If they have an out-of-network policy, then that it reimburses to them. So I'm pretty used to doing this with insurance, and the things that I talked about are currently possible. It is also possible to consider neurofeedback a form of relaxation training, and it's incorporated into what you do as psychotherapy. So in my world, that would be 90834, right? As
Cool.
A CPT code. Okay.
We're getting very positive response in the chat to your to these questions.
I would imagine that would get attention.
Yes. One just popped up from Greg. Can neurofeedback help with tinnitus?
Oh, what a good question. So tinnitus is a fairly complex condition. I have had good success with it. There is research on tinnitus. I would go back to that TAN book as a quick way of looking at that. A lot of information has come out on tinnitus as well as other conditions since this. This is the 3rd edition of that book, and there's, I would hope, a 4th edition coming soon. Usually neurofeedback in combination with a couple of other treatments. There's a cognitive behavioral treatment for tinnitus that has been useful. There is also some auditorily linked treatments, the Safe and Sound protocol that Stephen Porges and others have come up with that appears to be helpful with tinnitus. That could be a topic of another conversation, maybe.
Cool. Let's see, we have about 2 more minutes. So before we wrap this up, I do just want to let the audience know that we're planning to make these webinars more frequent. We will be doing one on September 14th at 2 p.m. Eastern, 2 to 3:30 p.m. Eastern. And that's going to be going over some depression stuff. Did you want to make a brief mention of that, Dr. Brown?
Sure. This would be an example of you all letting me talk about what what I think is really interesting and compelling. What I'd like to do is somewhat related or similar to what we did in the last webinar. The last webinar was around anxiety and kind of looking at the neurofunctional mechanisms underpinning anxiety. There's a similar way of thinking about depression, and I would like to speak to that, but I'd like to add to it the idea of how does that neurofunctionality underpin what we understand from our psychotherapy perspectives. Specifically, I'm going to look at a cognitive behavioral and an interpersonal perspective on depression, the way we tend to think about depression, learned helplessness, and some of the core concepts, and how that makes sense. It gives you a deeper way of making sense of what's happening with the patient if you have access to the brain data, and a deeper way to help them if you can actually do some brain training as well as psychotherapy. So I'm kind of weave those together.
Awesome. Well, I going to wrap this up. Mary, yes, you should be getting a link to the live stream. That was one of the questions. And then Amber, I'll reach out to you to answer your question personally, but this was really awesome. I hope that we can do more of these Q&As. Fascinating stuff. So thank you, Dr. Brown. And
Yeah.
if I don't see you before September, have a good rest of the August, but I'm sure I'll talk to you before then. And thank you to our audience for joining. You all were so awesome and super engaged and brought up really, really great points. So we look forward to doing this again.
Thanks, everybody.